Thank you, Dr. Harsh. And good morning to everyone. And I think all our esteemed panelists, as well as faculty and the audience as well. And thanks to Sipla for this kind invitation. And of course, Dr. Lalit Verma, who's been behind this wonderful program. I'm going to speak on the significance of ocular blood flow in glaucoma and how do we test it and how do we actually use this technology to look at managing our glaucoma patients. We all understand that there are a lot of non-IOP risk factors for glaucoma. Glaucoma being multifactorial disease involving several elements and not just intraocular pressure fluctuations, the gender, race, family history, some genetics, myopia, corneal thickness, so many factors to take into account when you're going to manage glaucoma. And of course, the vascular factors, vascular diseases like diabetes mellitus, migraine, hypotension, be it due to the drugs used for treatment of hypertension and so on. And of course, as a net result, the low ocular perfusion pressure. All of this has to be kept in mind in any individual patient you're dealing with when you manage glaucoma. First, a word about the ocular perfusion pressure in glaucoma. A lot of published literature, so I'm not going to go into each of these studies and describe what they have done. Just in brief, that the ocular perfusion pressure does seem to be important in certain subsets of glaucoma, where the intraocular pressure is not so important. The systolic perfusion pressure lower than 125 and a diastolic perfusion pressure of less than 30 has been shown to have a high risk of both glaucoma and increasing the risk of progression in these subset of certain patients where the perfusion pressure becomes important. Ocular blood flow deficits have been noted in glaucoma, retrobulbar, retinal, optic nerve head, and in the choroid as well. So various technologies have evolved to look at the circulation behind the eye, the retrobulbar vessels, the retina and the choroid, looking at mainly the choroid. So many technologies like color Doppler imaging, retinal oximetry, pulsatile ocular blood flow, interferometry, Doppler FDOCTs, and CSLO, so many technologies. And most of these technologies have not really come into clinical practice. And most of us don't use it in routine clinical practice. But however, a few of these technologies like color Doppler imaging and now the OCT angio has just come in. And these are the technologies which some of us use to look at the retrobulbar circulation, the retinal circulation, and make some sense out of these technologies. I'll talk briefly first about the color Doppler imaging, and which I have been using extensively over the last few years to look at the retrobulbar flow. Color Doppler imaging actually measures the flow velocity in retrobulbar blood vessels, and the outcome parameters include the peak systolic velocity, the end diastolic velocity, the flow velocities, as well as the calculated vascular resistance index called the RI, which is the formula which is used to calculate the RI. And the color Doppler imaging is performed by technique which evaluates the erythrocyte velocity in large ophthalmic vessels, such as the ophthalmic artery, the ciliary vessels. And this ultrasonic technique actually combines B-wave imaging with color Doppler, which looks at the movement of blood flow based on Doppler frequency shift. Compared to the other techniques, CDI has certain advantages, being non-invasive, does not require contrast medium, and once more, it is not influenced by poor ocular media like cataract or dense opacities. There's no radiation involved, so it's relatively safe and convenient, and has been in use in ophthalmology for more than 2 decades. And I'll show you a short video clip of how this was done. We have actually worked with This can be done both in the supine as well as in the sitting position, depending on the experience of the radiologist who's doing the test. And this particular mode done by our radiologist at our associated center is done in the supine position. It requires a lot of practice and skill, and it's best done by a radiologist because these machines cannot be used by ophthalmologists because of the PCNDT Act. So therefore, you need a qualified radiologist who's adept at doing this kind of things. And the amount of pressure which you apply, the amount of
this would be scanning back onto the ophthalmic artery. This is his ophthalmic artery. That's good. So from here, I will make my way up, and I'm going to try to look at the central retinal artery.
Yeah, I'm going to show you a few examples of the study which we had done with radiologist Professor Venkat Sai at the Bharat Scans in Chennai, as well as all of us who were trained with Professor Harris when he came to Chennai and taught us how to do the exact technique. These are some examples of color Doppler imaging used to look at normal PSV and EDV and the RI of the various vessels involved in the retrobulbar circulation. These are examples of abnormal CDIs of reduced diastolic flow, sharp peak velocities with sudden falls, loss of biphasic pattern, a lot of examples of abnormal scans. And this is how the report looks like, the findings from the ophthalmic artery, the CRA, the posterior ciliary vessels, temporal and nasal, as well as the measurements which you're actually seeing on the report. And we did compile the normative data based on the color Doppler imaging, looking at different age groups, and this is the mean of the ophthalmic artery, PSV, EDV, and RI for the CRA also, and the posterior ciliary artery. We also looked at the ocular perfusion pressure, the resistive index in relation to the intraocular pressure. All these were normal patients without glaucoma. So how do you interpret CDI? It's the velocity is absent. You can think of vaso-occlusive disease. If it is increased PSV, you can look at narrow vessels at the measurement site. Resistive index is a close correlation with the downstream vascular resistance. As a reversal of flow, you can think of a severe stenosis and ocular ischemia, like that example which Professor Harris was trying to demonstrate. A meta-analysis actually showed us that the PSV and EDV decreased in OA, the ophthalmic artery, the central retinal artery, the posterior ciliary vessels, and the RA increased in central retinal artery and the temporal posterior ciliary vessels in normal tension glaucoma patients. So this is where it stands today. The color Doppler imaging test cannot be interpreted as flow values unless the diameter of the vessel is also measured. So the technology is now looking at the diameter of the vessels. Therefore, you can start looking at the blood flow vessels maybe in the near future. The CDI measurements depend on the probe position and the Doppler angle, as Professor Venkat Sai was pointing out in this video. The long ciliary artery can sometimes be mistaken for the short posterior ciliary vessels. It is quite difficult to image the short posterior ciliary vessels, but with some experience, like our radiologist, he easily picks it up almost in one shot. The reproducibility of the CDI parameters among different parameters can be really different and is acceptable for certain larger vessels or parameters, but not quite good for the others. So you do need a skilled radiologist, and you do need the same technique and the same position, and make sure the patient is comfortable and there's no pressure on the eye when the CDI is being measured. A word about the OCT angio, which is a new kid on the block, and I think that the technology has evolved to the present time, which we do have good machines which give us a lot of information about the OCT angio. What is OCT angio? It's a relatively new, non-invasive, dye-free imaging modality which provides both a qualitative and a quantitative assessment of the vasculature of the retina and maybe the optic nerve head. It also enables visualization of choriocapillaris in areas of peripapillary atrophy. With OCT angio, the movement of the red cells is used as a contrast to delineate blood vessels from static tissues. And the features seen with OCT in eyes with glaucoma are reduction in the superficial vessel density in the peripapillary and macular areas, and complete loss of choriocapillaris in localized areas of the peripapillary atrophy, the so-called deep layer microvascular dropouts. These OCT angio changes correlate well with the functional changes seen on visual fields and structural changes seen on OCT, and I'll show you a few examples. The parameters which we get, as I mentioned, the vascular density of the optic nerve head, the flow index of the optic disc, the vascular density of the peripapillary retina, the capillaries, the vascular density in the macula, and this is said to correlate with the findings of patients showing the structural damage in fields as well as on OCT. The normal OCT angio, the NFAS projection resolved OCT angiograms of 4 plexuses seen in the right eye of a normal human shows you the NLFP, the nerve fiber layer plexus, the ganglion cell plexus, the intermediate plexus, and the deep plexus. The NLF, the nerve fiber layer, and the GCLP can be combined into the superficial vascular complex, whereas the ICP and the DCP can be combined with the deep vascular complex, which is primary capillary networks. This is how the technology works. And this is an example of the SVC angiogram showing you a 6 mm square superficial vascular plexus complex, and shows you the defect both in the GCC as well as the corresponding change in the vascular pattern. So you do need to look at a 6x6 pattern of the GCC as well as the SVC angiogram, because a smaller 3x3 or a 4x4 may miss the common patterns of damage in glaucoma. This is an example of a normal angiodisc. This is from the angioplex. And if you look at the angio view of the disc, and looking at the RPC, which is the radial peripapillary capillary vessel density, and this is the normal. And this is showing you the inferior wedge with the corresponding change in the radial peripapillary change in the inferior wedge area. Example of same wedge with GCC showing you the change and the corresponding change in the visual field. So these are a few examples. How does the OCT actually differ from the OCT itself? The OCT angio actually detects both dysfunctional and so-called dead ganglion cells, whereas the structural OCT can probably detect only the lost ganglion cells. So probably in very early glaucoma, sick dysfunctional ganglion cells have lower metabolism that leads to reduced capillary density. And this density is probably picked up with the OCT prior to the apoptosis of these ganglion cells. So we can probably detect glaucoma earlier than OCT. The other studies have shown that the OCTA parameters correlate better with visual field parameters than structural OCT parameters. This is partly due to the lessening of the floor effect with the OCT measurements, and probably the OCT has the potential to improve the monitoring of glaucoma in moderate to advanced stages where the floor effect comes into play with the structural OCTs. And a word about the ocular blood flow. So what do we do when we pick up a structural change in the blood flow, the change in the capillaries, a change in the reduction in the blood flow? So some of these studies have shown the effect of drugs in the possible role when you pick up a decrease in the blood flow. Again, various technologies have been used, and the one which has been most commonly used in the past has been the color Doppler imaging. And about 75 to 80% of all of these studies have shown that one drug which is possibly effective in improving or increasing the ocular blood flow could be dorzolamide as carbonic anhydrase inhibitors. And that's one thing which we could do when you pick up a change and a decrease in ocular blood flow. This is the only drug which is possibly have some promise of increasing ocular blood flow. There are many challenges of the availability and limitation of directly assessing ocular blood flow in humans, the technologies, the need for experienced technicians, and also to correlate the vascular findings with disease progression. Which came first? The vascular change came first, or the structural change came first? And of course, the various treatment options, what are they available once you pick up some change in the ocular blood flow? So take-home message for the practicing clinician could be that estimate the ocular perfusion pressure and consider ocular blood flow studies in certain subset of patients. CDA has been an established tool for assessing the ocular blood flow, but has many limitations, like as I mentioned earlier. The OCT angio is a more recent development, but is yet to be incorporated for routine clinical diagnostic use. I would consider ocular blood flow studies in normal tension glaucomas, unexplained progression in these kind of patients, and whenever you strongly suspect a vascular etiology as the cause for glaucoma. And this is from the first workshop which Professor Alan Harris conducted in Chennai. And we are fortunate to have worked with him since then, and we still continue to work with him and looking at mostly the color Doppler imaging and now the OCT angio and its role and the role of drugs in OCT angio. Thank you for your attention.
Thank you so much, Murali. I think that was wonderfully done, and it must have clarified for our people. And actually, we were discussing OCTA also before.